Hi friends, welcome to Fastcoder 21 Medical Coding YouTube channel. The purpose of this channel is to share the knowledge, gain knowledge. If you are visiting for the first time, please click on subscribe button to motivate us. Please like, subscribe, comment and learn. So today we are going to learn basic interview question and answers of CPT surgery in medical coding. So as all of us know, CPT surgery is little bit difficult compared to diagnosis coding. In order to code CPT surgery properly, we need to know basic guidelines which are common for all sections in CPT. So in this session, we are going to learn few of the basic interview Q&A of CPT surgery. So whenever you go interviewer asks you, tell me about yourself. You need to tell about your past, present and future. Next one, what type of charts have you coded? Tell the interviewer what specialties you have coded in the previous company or current company. Next one, how many specialties have you coded? So we need to tell the what are the specialties we have coded or we can code like ED, IP, SDS. Next one, what is the full form of ABN? So basically ABN means Advanced Beneficiary Note. So an Advanced Beneficiary Note, also known as a waiver of liability, is a notice a provider should give you before you receive a service if based on Medicare coverage rules your provider has reason to believe Medicare will not pay for the service. So basically whenever the provider provides service to the patients, if providers think that he will not get money from the Medicare, he will give us one note which is advanced beneficiary note. Using this note, provider tells us that if Medicare will not pay the money, the patient needs to pay the money to provider or provider services. What is the full form of ASC? ASC means ambulatory surgery centers or facilities other than hospitals that provide outpatient surgical services. Next one, what is the use of EEG? EEG means electroencephalogram. So we will use EEG to detect and investigate epilepsy, a condition that causes repeated seizures. So next one, what is the use of EMG? EMG means electromyography is a diagnostic procedure to assess the health of muscles and the nerve cells that control them, like motor neurons. Here myo means muscle, graphy means recording. Using electric signals, physician will record the muscles. Next one, what is the full form of HIPAA? HIPAA means Health Insurance Portability and Accountability Act of 1996. Next one, do you have any idea about NCCI edits? Yes, I know that CMS developed the National Correct Coding Initiative program to prevent inappropriate payment of services that should not be reported together. So in order to use up inappropriately, Medicare or CMS developed NCCI edits. Next one, what is MUE? MUE means medically unlikely edit. So medically unlikely edits are benchmarks recognized by the CMS that are designed to prevent incorrect or excessive coding. If the number of units of service billed by the same physician for the same patient on the same day exceeds the maximum number of permitted by the CMS, the MAC will deny the code or return the claim to the provider for correction. So basically, if you use one example, MU means medically unlikely edit. For example, if you take any a procedure, next one, what is RS and I? RS and I means radiological supervision and interpretation. So basically in CPT, we have few codes which are combined with RS and I. For few codes, we need to use RS and I separately. Next one, what are HCPCS codes and its levels? HCPCS means Healthcare Common Procedure Coding System, and HCPCS consists of Level 1 CPT, Current Procedure Terminology codes, and Level 2 codes, a standardized coding system that is used primarily to identify products, supplies, and services included in the CPT codes. Next one, what is the frequency of CPT updates by AMA? So AMA updates CPC yearly once. So here we have mentioned annually. Next one, who has developed NCCI program? CMS has developed the National Correct Coding Initiative program to prevent inappropriate payment of services that should not be reported together. Next one, do you have any idea about column 1 and column 2 edits? Yes, I have. In column 1, each table contains edits which are pairs HICPIC CPT codes that in general should not be reported together. Each table has a column 1 and column 2 HICPIC CPT code. If a provider or supplier reports two codes of an edit pair, the column 2 code is denied and the column 1 code is eligible for payment. However, if it is clinically appropriate to use an NCCI PTP associate modifier, both the column and column 2 codes are eligible for payments. So basically, column 1 code contains most comprehensive code and column 2 contains less comprehensive. So whenever there is a coding of comprehensive and less comprehensive code, so basically column 1 contains complex procedure, column 2 contains less complex procedure. You can call column 1 as comprehensive, column 2 as like less complex or non-comprehensive. So can you tell me one example for column 1 and column 2 edit? Yes, I can. Basically, the column 2 code is often a component of a more comprehensive column 1 code. For example, a provider shall not report a vaginal hysterectomy code and total abdominal hysterectomy code together. So, vaginal hysterectomy is more comprehensive and total abdominal hysterectomy is less comprehensive. Next one, what is OPPS? OPPS means Outpatient Prospective Payment System. The OPPS is the system through which Medicare decides how much money a hospital or community mental health center will get for outpatient care provided to patients with Medicare. The rate of reimbursement varies with the location of the hospital or clinic. So basically, Medicare will decide the amount to provide to the hospitals or clinics in order to providing their services. Usually, we'll call it as outpatient prospective payment system. Next one, can you report CPT code 58262 vaginal hysterectomy for uterus 250 grams or less with removal of tubes and ovary with CPT code 58260. So which is vaginal hysterectomy for uterus 250 grams or less plus CPT code 58720 salpingo oophorectomy complete or partial, unilateral or bilateral separate procedure. Answer no. We can't report multiple HCPCS codes when we have a simple comprehensive HCPCS or CPT code. So basically 58262 is combination of hysterectomy plus salpingectomy, and second one 58260 plus 58720 is both are different procedure, but these two procedures are combined in 58262. So whenever physician performs vaginal hysterectomy plus Salpingo oophorectomy, we need to code most comprehensive 58262. We can't code 58260 and 58720. These are separate procedures. Next one, when do you append RT and LT laterality modifiers? So if you don't have bilateral procedure code, we need to append RT and LT modifier to CPT code. If you have bilateral code, we no need to add RT and LT. We can add 50 modifier. Next one, how do you code if the physician performs exploratory laparotomy with open abdominal procedure like total abdominal colectomy? So basically, exploratory means physician will check inside the abdomen. So basically, exploratory laparotomy is included in total abdominal colectomy. So we no need to code exploratory procedures along with the most comprehensive total abdominal colectomy. When do you code biopsy separately? We shall only report a biopsy separately when pathologic examination results in a decision to immediately proceed with a more extensive procedure like excision, distraction removal on the same lesion or when performed on a separate lesion. Next one, can you report a biopsy separately when it is to assess resection margins or to verify resectability, or when performed and submitted for pathologic evaluation completed after performing the more extensive procedure? We can't code biopsy separately. So what is downcoding? And tell me one example. So downcoding, other name is undercoding, which means if CPT code exists that describe the services performed, the coder must report this code rather than reporting a less comprehensive code with other code describing the services not included in the less comprehensive code. We have an example here. If a physician performs unilateral partial mastectomy with axillary lymphadenectomy, we need to report 19302 mastectomy partial with an axillary lymphadenectomy. We shall not report 19301 mastectomy plus CPT code axillary lymphadenectomy separately 38745. Next one, what is upcoding? Upcoding means CPT code may be reported only if all services described by that codes have been performed. For example, if physician performs superficial axillary lymphadenectomy, we shall not report CPT code axillary lymphadenectomy. So basically, in upcoding, we are coding more uh, severe than the service performed. So, for example, if the physician performs superficial axillary lymphadenectomy, we need to code superficial only. We can't code complete lymphadenectomy or deep. What is UOS? UOS means units of service. Basically, each CPT code has a defined unit of service for reporting purpose. For example, anatomical modifier E to E4, FA to F9, and TA to T9 have a maximum allowable of 1 unit per anatomical site for a given data service. Next one, will you code wound irrigation with wound treatment? Based on CPT guidelines, wound irrigation is integral to wound treatment. Therefore, we no need to code wound irrigation separately. Next one, do you have any idea about PTP edits and tell me few examples? PTP edits means procedure to procedure edit. When a service that are integral to another service or component parts of the more comprehensive service. When integral component service have their own CPT codes, NCCI PTP edits place the comprehensive service in column 1 and component service in the column 2. Since a component service integral to a comprehensive service, it is not separately reportable. The column 2 code is not separately reportable with column 1 code. Some services are integral to large number of procedures. Other services are integral to more limited number of procedures. So basically, PTP edits means procedure to procedure edit. So here, as usual, Whenever we have a more comprehensive procedure, we need to code more comprehensive procedure rather than the two less comprehensive procedures. So next one, tell me few examples of services integral to large number of procedures. Generally, the following all are included in the more comprehensive procedure or integral to the large number procedure like draping, insertion of IV access, urinary catheter, all those things included in the large number of procedures. Those we need to code. We don't need to code separately. Next one, can you code myringotomy with cerumen impaction removal code? Answer no, because myringotomy requires access to the tympanic membrane through the external auditory canal, hence removal of impaction is not needed. Next one, will you code separate endoscopies at same time? Yes, we can code when separate endoscopies of anatomically distinct areas with different endoscopy may be reported separately. Like at the same day, if the patient has thoracoscopy and mediastonoscopy, we can code. Why means these two are anatomically different locations. What is scout endoscopy? Basically, scout endoscopy means is the endoscopy is to assess surgical field, anatomical landmarks, extent of disease, like that. And it is not separately reportable with an open pulmonary procedure such as lobectomy. Next one, what is diagnostic bronchoscopy? Diagnostic bronchoscopy is a procedure where physicians look at our lungs and air passages to find any disease or mass. Next one, can you code endoscopy procedure with non-endoscopy procedure? No, if an endoscopy procedure is performed at the same time or same patient encounter as a non-endoscopic procedure to ensure no intraoperative injury occurred or verify the procedure are performed correctly, the endoscopic procedure is not separately reportable with the non-endoscopic procedure. So here patient has one endoscopic procedure and non-endoscopic procedure. Usually physician will perform endoscopy after the non-endoscopic procedure in order to check any damages or any injuries. So we will not code this endoscopy procedure along with non-endoscopy procedure. Next one, can you code laparotomy and adhesiolysis with colectomy and why? We can't call laparotomy and adhesiolysis with colectomy as colectomy is a complex procedure. No, because a colectomy requires exposure of the colon, the laparotomy and adhesiolysis to expose the colon are not separately reportable. Next one, how do you code elective endotracheal intubation? Answer, airway access is necessary for general anesthesia and is not separately reportable. There is no CPT code for elective endotracheal intubation. CPT code 31500 is script an emergency endotracheal intubation and shall not be reported for elective endotracheal intubation. So basically, endotracheal intubation is included in the general anesthesia that we no need to code separately. So if the patient has emergency endotracheal intubation, we need to use 31500 series code. Next one, what are the procedures included in endotracheal intubation? Usually, visualization of the airway is a component part of endotracheal intubation, and CPT codes describing procedure that visualize the airway shall not be reported with endotracheal intubation. Next one, what is a separate procedure? So, separate procedure is a procedure where a procedure designated by the CPT code descriptor as separate procedure is not separately reportable if performed in a region, region anatomically related to the other procedure to the same skin incision, orifice or surgical approach. So when there is a next one, what is a modifier? Modifier indicate that a service or procedure has been altered by a special circumstance without changing the definition or code for the service. Next one, can you code excision and incision at same site? No, as excision and removal includes the incision and opening of the organ. We can't code excision and incision at the same time. Why means using the incision only, physician will go inside and excise the organ or mass. Next one, can you code abdominal hysterectomy with vaginal hysterectomy and why? So basically, we can't code abdominal hysterectomy with vaginal hysterectomy, as multiple approaches to the same procedure are mutually exclusive of one another and shall not be reported separately. For example, both vaginal hysterectomy and abdominal hysterectomy shall not be reported separately. Next one, how do you code if a laparoscopic hysterectomy is converted to an open hysterectomy? So based on CPT guidelines, when laparoscopic procedure is cancelled or converted to a open procedure, we need to code the open procedure only. Here we can code open hysterectomy. Next one, how do you code treatment of complication due to primary procedure? Usually, the global surgical package for an open operative procedure includes all intraoperative services that are normally a usual and necessary part of the procedure. Additionally, the global surgical package includes all medical and surgical services required of the surgeon during the postoperative period of surgery to treat complications that do not require return to the operating room. So basically, global surgery package includes all the intraoperative service. So here we no need to code complications if the patient is in the global period. Next one, when do you code E&M separately? So an E&M service is separately reportable on the same date of service as a procedure with a global period of 0, 1 or 90 days under limited circumstances. What is a major surgical procedure? If a procedure has global period of 90 days, it is defined as a major surgical procedure. Next one, when do you use 57 modifier? So if an E&M service is performed on the same date of service as a major surgical procedure, for the purpose of deciding whether to perform the surgical procedure, the E&M service is separately reportable with modifier 57. What is a minor procedure? If a procedure has a global period of 0 or 10 days, defined as minor surgical procedure. So when do you use modifier 25? A significant and separately identifiable E&M service unrelated to the decision to perform the minor surgical procedure is separately reportable with modifier 25. What is modifier 24? Unrelated evaluation management service by the same physician or other qualified healthcare professional during a postoperative period. Tell me few examples for anatomic modifiers. E to F4, FA, F1 to F9, TH, like that. Next one. Tell me few global surgery modifiers. 24, 25, 57, 58, 78, 79 are global surgery modifiers. Thanks for watching Fast Quarter 21. Here we will end today's session. Please like, comment, share and learn by Fast Quarter 21. If you have any comments, please mention in the comment section. Happy coding, guys.